Hi, and welcome back to part 3 of the lecture on anthropometry. We're now going to talk about some other measurement techniques, but before we do that, we're going to just quickly reflect on some information about anthropometric measures or basic measures in unusual populations, but particularly in growing populations. So a quick talk about children and measuring anthropometric weight and height and head circumference. These are the key measures that are usually taken in a pediatric population. There's some descriptions and some images here, babies being weighed without clothing on a calibrated scales and to what extent the precision is recorded, recumbent length, placed, the baby being placed on a recumbent stadiometer, and then head circumference from a non-stretchable tape being placed around the broadest part of the head. There's some common problems. Working with babies is always a bit of a challenge when it comes to taking an objective measure, because they may not necessarily always be compliant, but nonetheless those measures are still fairly routinely taken. And when they are taken, they're usually interpreted relative to growth reference data, depending on the parameter that you're measuring. So comparisons with previous measures of the same child on the personal infant health record. So that they're often plotted on a growth chart, but which is a comparison to population norms, but with the individual being tracked within that reference population. Now we have different reference populations. The Centre for Disease Control or the World Health Organization charts are the two most prevalently used growth charts. It's important to note that the CDC ones were based on predominantly formula-fed and starting solids at about 2 months of age, and how applicable that is to what we normally see in Australia is up for question. Here's an example. This is the weight for age for, in this case, girls. Thankfully, the colour-coded ones can give you a hand because they're often blue and pink, depending on what reference population. But what you'll routinely see along the x-axis is the age, and then along the y-axis you will typically see the parameter of interest, which in this case is weight. And we have a series of lines, and those lines represent percentiles. So the green line in the middle is the 50th percentile. And in this example, we have a 75th and a 95th percentile, I believe. Just give me 2 seconds and I'll blow it up and I can have a look. So we have the 85th and the 15th and the 3rd or the 97th percentile. So it just depends on the particular growth chart that you're working with, and then you would make an interpretation on these growth charts based on where the person's age and parameter fell. So if we had a data point, and for some reason I always seem to be struggling to pick up the cursor, so I'll just try my other technique again for a minute. If we see if that works for you. Doesn't seem to be. Give me 2 seconds. I'm getting absolutely nothing. I might go to here. That might be easier. Do we have any luck at all? Nope. And last chance. Okay, we're not getting anything. Okay, but if we were, for instance, had a 1-year-old and their weight was registered at 7 kilos, so if we follow 7 kilos along and we pick it up on the, here we go, and we do have a value. And so here's 7 kilos here, and we would say we were dealing with a 1-year-old. So this value is just below, just a fraction below this percentile here. You would describe that value as less than the 3rd percentile. Okay, you wouldn't say, oh look, I think it's about the 2nd percentile or the 1st percentile. You would just describe it as less than the 3rd. Equally, if the value was slightly higher and fell in this range here, you would describe that as being between the 3rd and 15th percentile. If the value fell right on the line, you could certainly describe that as on the 50th percentile, but anything in between or anything over, you would describe it as between or greater than or less than, depending on where they are in the relationship. Here's a boys. So that previous one was birth to 2 years, and you'll often find that the growth charts are divided into a birth to 2-year percentile, and then a 2-year to adulthood, in this case 2 years to 20 years. These are the CDC values. This is stature for age and weight for age percentiles for boys. And again, you can see you can plot both values here. You've got age along the bottom and then the percentiles going up. And in this instance, we have the 5th, 10th, 25th, 50th, 75th, 90th, and 95th percentile line. So we've got a whole range of smaller graduations listed out here in this one. So quickly now, quick activity. Describe the growth pattern of a child who at 3 years of age weighed 12.2 kilos and was 94 centimetres tall, and then at 10 years weighed 43 kilos and was 147 centimetres tall. So bring this along to the tutorial, and we can have a look at your plot and have a look at how you've described the response to that. In terms of adjustments in children, we have weight, length, head circumference adjustments for premature babies. So babies born prematurely, because obviously these youngsters, if you plot them on a normal growth chart, will be much younger than their counterparts. So for height, for their head circumference, the adjustment continues until they're 18 months of age. For weight, it's almost 2 years, and for length, it's almost 3 years after they're born. So what you need to do is determine or go back to conception and plot their age based on their conception weight rather than their actual birth date. So babies born less than 32 weeks, there are actually low birth weight charts that you can use, and babies born between 32 and 37 weeks are plotted on the preterm chart until 2 weeks after their estimated due date. And then from there, they're plotted on the usual chart. But their age is gestationally corrected. So we don't expect premature babies, or we don't compare premature babies to full-term babies and expect them to grow or have the same height profiles. We make adjustments in those cases. There can be a bunch of reasons why someone's, as a child, might be greater than the 95th percentile. So if we're looking at weight, it could be that they've got tall parents, they could be tall. It could be that the child is overweight. It could be that the child has edema. If they're greater than the 95th percentile for length, it could be that, again, they've got genetic predisposition. They could have accelerated maturation or conditions such as Marfan syndrome, which is a connective tissue disorder. And in terms of weight for length, it could be obesity, it could be edema, achondroplasia, which is again another inherent sort of genetic condition, hydrocephaly, so a central nervous system anomaly linked with spina bifida. So this is Marfan syndrome. It's a condition of connective tissue, affects the long bones of the skeleton, therefore very tall stature with long limbs, fingers and toes. So in that case, the individual is going to be a lot taller than their average population-based counterpart, and maybe lighter as well. But their weight is probably going to be masked a little bit by their height. So their weight may be normal, but if you were to compare them on a BMI chart, it would be obviously a lot lower because they're much taller. achondroplasia, which is, as I said, is a genetic disorder affecting bone growth. So arms and legs are very short, while the torso is normal. So short hands with stubby fingers is some of the characteristics of achondroplasia. Reasons a child may be less than a 5th percentile. Again, these are sort of almost converse: shortness, parents, malnutrition, delayed maturation, weight for length, might be dehydrated, recent malnutrition, or as I said earlier, they could be very, very tall relative to their weight and have something like Marfan syndrome. Okay, let's change tack and talk about other measures of body composition. Many of you will be familiar with bioelectrical impedance, or BIA. This is a foot-to-foot device. It basically uses an electrode signal looking for impedance, with the proportion of impedance being greater with a larger amount of body fat. We have a range of different impedance devices. So we've got the cheap foot-to-foot ones, we have some hand-to-foot ones, and the device that is at the bottom is the device that we have that I'll bring to the tutorial. It's a hand-to-foot device as well, but can be used in hospitalised patients. It uses a multi-frequency BIA, whereas the foot-to-foot cheap versions usually just use one frequency. Basically, the electrical current is passed through the body. If you're going foot to foot, it will take the path of least resistance, so it probably won't travel up and give you an impedance value for the upper part of the body. It will just give you the lower limbs. That's why the foot to hand versions are considered a little bit more appropriate, because they would take into consideration impedance across the body. And we'll show you how to place the electrodes and take a measure. It's not invasive, it's not painful, and can give you some quite useful information. Densitometry was one of the traditional ways. Underwater weighing is the sort of almost gold standard, where you're basically displacing water, and the individual is on a scale, and depending on how much they weigh underwater can determine how much fat they have relative to their total mass. So here's an example of an individual or two individuals, Jack and Dave. If you have a look at their height and their weight, if they were measured on land, they are the same, but underwater they weigh differently. So Jack weighs 6.5 kilos underwater, whereas Dave only weighs 5 kilos. So in that instance, given the density of fat mass to lean mass, we would see here that Jack on the left-hand side would have a lower fat weight and more fat-free weight, and so ultimately would be a leaner individual than Dave, who weighs less underwater. These tanks are not all that prevalent anymore, and to have yourself weighed underwater can be a little bit claustrophobic, a little bit disconcerting for some individuals, because you need to weigh the person after they expel as much air from their lungs as they can, which is obviously the opposite of what people usually do when they go underwater. A similar sort of technique, if you like, involves the displacement of air displacement plasmography. These are BOD pods, or on the left is a P pod for pediatric population. This measure is again not painful, but is reliant on reasonably expensive equipment. We don't have one of these or either of these devices on campus. We do, however, have about 4 DEXA machines on campus, and this is what a DEXA machine looks like, which is originally designed for bone mineral density calculation, but you can look at whole body composition as well, using a dual ray X-ray device to look at a sort of 2-dimensional view of the body. Putting reference markers on the outside of the body can determine or separate lean mass from fat mass. Okay, the final thing I just want you to have a think about before our class is an applied activity. Here's 5 scenarios of different people who may come to see you as a dietitian. And I want you to think about what anthropometric measures you might take in these different scenarios, and I'll talk to you about them in class. So the first one's a 3-year-old child visiting with her mother, who's concerned that she may not be growing appropriately. So what measures would you take in that context? The next one is a 36-year-old lady who visits your private practice for weight loss advice. What measures would you take in this instance? Would you take them on the first visit? Would you take them routinely? And think about the strategies that you might use for collecting those measures. A 25-year-old Ironman triathlete training for an upcoming event, and you wanted to measure their body composition, what measures would you take? A 65-year-old hemodialysis patient on a transplant list, so what do you think are the important parameters for that individual? And what happens if you want to know across a population like a hospital ward, general medical patients, what do you think are the important parameters to look at to determine how well your population is doing in a larger group sense? So have a think about these. Maybe write down on a piece of paper for these 5 scenarios what you would measure, and we'll have a chat about them in the workshop. I look forward to it.